Thank you very much, and I'm especially pleased to be a part of a conference that has actually put nutrition equity issues as part of the agenda. So I think, first of all, kudos to those people who organized this thing. It's been great so far, but I love that this is part of the program. So my contribution, such as it is to this event, is to focus a bit on nutrition and health equity issues in Canada, and in particular policy opportunities to better address those issues. I want to start by offering a little bit of a context of nutrition and health equity in Canada. You've heard people talk about the burden of diet-related disease, things like heart disease and hypertension, and my small addition to that pile of information that's already been shared at this conference is to simply point out that these things have profound social gradients. The probability of having heart disease or hypertension moves in direct relationship with income. So there is a strong social gradient. The less money you have, the more likely you are to have those conditions. The data are even more stark for diabetes. Here you see 3 periods of data from the Canadian Community Health Survey, and disparity risk ratio. The gap between rich and poor in terms of the likelihood of diabetes persists over time, even though the rate is rising for some higher groups as well. It's also true that we can see social gradients in diet, and our best window into that comes from fruit and vegetable intake, I think for a few reasons, and one of them is that that's the thing that is most frequently monitored in Canada through a very short food frequency questionnaire that appears on the Canadian Community Health Survey. What you're seeing here is fruit and vegetable intake in relationship to income and education, and in both cases there are subtle but significant gradients whereby the higher the income, the greater the consumption of fruit and vegetables as measured by that index. Most recently, there's been a publication by some staff at Health Canada looking at changes over time in fruit and vegetable consumption in our country. And what they show is a drop in fruit and vegetable consumption that is largely a function of the decrease in consumption of fruit juices. But what they're also showing in that paper is that the drop is greater for low-income people than higher-income people, such that perhaps we are starting to see an even wider disparity in diet quality as measured by fruit and vegetable consumption. So this is the backdrop against which we have the healthy eating strategy. We've got a strategy that's designed to deal with dietary factors that associate with chronic disease risk, and that's chronic disease risk that is inequitably distributed in our society such that lower income, lower education people are more exposed. And it's a diet-related risk that when we look at our best marker of a healthy diet, fruit and vegetable intake, we can see also an inverse gradient with income. Okay, so to think about how this strategy will work going forward, it's worth us spending a couple of minutes, I think, on the theory of intervention. And for that, I draw upon a very ancient paradigm from Jeffrey Rose, who is equally ancient to me. And many, many years ago, he published a paper called Sick Individuals and Sick Populations. And in that paper, it was a landmark thing for population strategies overall. He started to make a very clear distinction between high-risk or medical model interventions, whereby you identify people who are at risk of a condition or people already showing elevated cholesterol levels, high BMI, high blood pressure. You intervene on them to alter their risk factors, so to make them healthier people. That stands in stark contrast to population strategies where you're working to shift the risk in the population overall. The healthy eating strategy is a population strategy. So it's attempting to deal with determinants of diet-related chronic disease by shifting the population's intakes of those determinants. The emphasis is on sugar, sodium, and fat, and or saturated fat, with a particular focus given, and this is less explicit than the sugar, sodium, and saturated fat component, but the nature of the interventions, I would argue, is particularly targeting the consumption of highly processed foods. Okay, so let's take a look at those parameters. But first, the embodiment of the population strategy as it relates to the shifting of risk in the population, I think can be drawn out from the report from the Sodium Working Group that they issued in 2010. And what you can see here are three distributions of sodium intake. The highest one is the distribution, or was at that time, the distribution of actual intakes of sodium in the Canadian population, a distribution that was way too high. And then there were two sets of goals identified in that report that were shifting the distribution down. That's the idea of a population strategy. You take a distribution of something that is a determinant of chronic disease, and you work to move it to a zone that is putting people less at risk. Okay, here's what sodium intakes look like. This is me drawing on work from Lindsay McLaren, and you'll see Lindsay McLaren's name repeatedly in these slides. She is a major inspiration for my thinking on this topic. So Lindsay did a whole lot of work with the 2004 Canadian Community Health Survey to try to see how sodium intakes related to income and education. And what she found was that those relationships were basically flat. There was no evidence, even though we've got a differential in hypertension, and we've got an income differential when it comes to fruit and vegetable intakes. In fact, everybody in the population has sodium intakes that are too high, and there was no indication of differentials by income or education. The work by Catherine Gray-Donald and Sean Mark, also using the dietary intake data from 2004, looked at consumption of sweetened beverages, and this is amongst children 9 to 18 years of age. Same finding, basically a flat line. High exposure across the board, but no indication of a gradient in consumption. Here's also work on the percentage of energy from saturated fats amongst that same group of children, again from Gray-Donald and Sean Mark. And again, a story of no differential in terms of saturated fat. So we've got a healthy eating strategy that is targeting three components of diet that, from our best dietary intake data now in the public domain, which is 2004 data, we have no social gradient apparent in people's exposure. Everybody's exposure is high, and so we've got a population strategy to lower risk. One more, the focus on ultra-processed foods. More recently, we've seen a publication report that was issued by the Heart and Stroke Foundation, commissioned work from Claude Maubarek, and this is looking at the consumption of ultra-processed foods by income and education, and again, once they take into account things like age and sex, these are effectively flat lines. No indication that lower income people are overly exposed then to saturated fat, to sweetened beverages, to sodium, or to ultra-processed foods, where basically those risk factors in our population appear ubiquitous. Okay, so we're embarking on a fairly major direction of public policy intervention with the healthy eating strategy. One scenario is that that strategy will simply pick up the distribution of usual intakes for any one of those components and lower it to a place that is healthier for our population. That's the ultimate impact of an intervention that affects everyone equally, picks them up and moves them down the ladder. Scenario 2 is a little more problematic, however, and that's the case that happens when an intervention works better for some members of the population than others. And in that case, we have the possibility then of an intervention that actually introduces or increases health inequities by disproportionately affecting those most at risk. Lindsay McLaren has advanced the thinking on this notion of scenario 1 and scenario 2 with a paper that she and Lynn McIntyre and Sharon Kirkpatrick published a few years ago, talking about the nature of interventions that would move the whole population equally versus those that would create greater disparity within the population. Those that are scenario 1, moving everybody equally, Lindsay refers to as structural interventions. So interventions that are working with root causes of disease and shifting the exposure to those root causes across the board. In contrast, scenario 2 are what Lindsay refers to as agentic interventions or behavioral interventions that are perhaps disproportionately affecting some members of the population more than others. A structural intervention targets the context for behavioral change, shifting exposure of everyone in the population to whatever the thing is that's a problem. A simple example of a structural intervention in Canada is the introduction of mandatory folic acid fortification back in the late 90s. There was a point where legislation came in that mandated the addition of folic acid to cereal and grain products of a particular class. When that happened, everybody's folic acid intakes increased. Everybody's exposure to folic acid rose instantly, overnight, with the introduction of mandatory fortification. We didn't have to do anything differently. We just kept eating whatever we were eating, but now we were receiving more folic acid. And with that, what we saw was a reduction in neural tube defects, which was the goal of that intervention. So there's a powerful intervention of a structural, a powerful example, rather, of a structural intervention that alters risk in the population overall. Contrast that to the agentic or behavioral interventions that are focused on shifting the behavior of individuals through the provision of information or education. Those interventions typically affect people who are affluent, educated, and health conscious, people who are already likely to be at lowest risk of whatever the disease is that we're trying to impact. And so the end result of an agentic or a behavioral intervention can be to widen inequalities. Okay. So let's talk about the healthy eating strategy, shall we? The idea of agentic and structural interventions is that they sit along a continuum. There are two poles on a continuum. At one end of the continuum, we have the front of pack labeling and the changes that have been made already to the nutrition facts table and the ingredient list, the clustering of sugar-containing ingredients. We also are soon going to receive a revised Canada's Food Guide. All of those interventions can be seen as agentic or behavioral in that they're designed to influence people's knowledge and attitudes towards healthy eating in ways that cause them to shift behaviors and make different choices. At the other end of this continuum, we've got the plan to eliminate trans fat from their food supply. That is absolutely a structural intervention in that it is going to change the food supply in a way that affects all of our exposure to trans fat, irrespective of what we personally do. In the middle zone, we have a couple of other things. We heard Will Yan talk last night about continued work with food manufacturers and also restaurateurs and fast food outlets to try to work with them to lower the sodium content in their foods. And this morning, we had an excellent panel talking about the restriction of marketing of unhealthy foods and beverages to children. These latter two strategies sit somewhere in the zone between agentic and structural. They're not so clearly either one, so we'll talk more about them. But let's start by taking a closer look at the upper end of this continuum, the structural interventions. We can learn a lot about how structural interventions work by looking at the history of trans fats in Canada. By the time we got to the 1990s, there was fairly broad consensus in the scientific literature that trans fats increased cardiovascular disease risk. So by the time we got to the end of that decade, it was pretty obvious that the right thing to do was to lower consumption of trans fats and to lower exposure. Canada and the US and some other places started to insert trans fat into the nutrition facts table so that if someone wanted to select a product with lower trans fat, they could see it on the nutrition facts table, because before then, it had been literally invisible to people without an education around how to read ingredient lists. So in 2005, we saw the introduction of mandatory nutrition labeling with an inclusion on the nutrition facts table for a line about trans fats. Around that time, we also had a trans fat task force convened, and they reviewed the evidence on trans fat and the possibilities for intervention, and they recommended very strongly that there be regulation to reduce trans fats in the Canadian food supply. But that didn't happen. Instead, what we embarked on was a 12-year period of voluntary reformulation by industry, with targets created. So there was a structure created by Health Canada for the nature of the changes that they hope to see. For a number of years, the first 6 years in that period, there was monitoring of the amounts of trans fats in the food supply, so tracking reductions in trans fat, in some ways similar to the tracking of reductions in sodium in the food supply that we heard about last night. And now, finally, in 2018, we're seeing regulations rolling in. So it's been a long journey. But we can learn something about this intermediary period by looking at what happened to the Canadian food supply when industry was stimulated to reformulate by the insertion of trans fats on the nutrition facts table, and then by this kind of structured voluntary government monitoring or not monitoring, or threats of regulation or not, to lower trans fats in the food supply. Studies that happened in the early years following the implementation of the nutrition facts table showed a couple of things. They showed that absolutely there were products being reformulated to remove trans fats, but there were also products with trans fat in them. And there was a clear price differential whereby those without trans fats cost more money than those with trans fats. But in time, more and more trans fat came out of the food supply, and it got harder to find foods with trans fat in them. But a startling example for me of the inability of voluntary reformulation to actually impact the entire population comes from some work that we did with the Salvation Army. When industry is asked to reformulate and it's voluntary, it's a marketing decision. And there are some segments of the market for whom there will be no gain to reformulation, and those are segments of the market where choice is not relevant. So in 2011 and 12, we did a piece of work with the Salvation Army to try to help them improve the quality of the meals in their homeless shelters. As part of that study, we did a purposive sample of 14 shelters in the country where we did a detailed examination of the foods being provided to the people in the shelters. And what we found was a profound presence of trans fats. Hydrogenated margarines were commonplace. I hadn't even understood that this was a question we should be asking until I visited a shelter, a Salvation Army shelter across the street from where I work in Toronto, and saw huge bins of trans fat containing margarines in the kitchen. But there was a startling exception in this study, and that was the shelters that we sampled in British Columbia. Why? Because in British Columbia in 2009, they had enacted legislation banning trans fats from food service establishments. And wonderfully, British Columbia counted Salvation Army shelters as food service establishments, and so they enforced that ban even there. And so people in Salvation Army shelters in British Columbia weren't being exposed to trans fat. Now, Calgary did a similar thing. And I don't have data on the shelters in Calgary. I wish I did. I will, when I get back to my office in Toronto, see what we do have on the shelters in Calgary. But I can't help but focus on this example just after having heard the very, very provocative talk by Kim Kessler last night, that local action matters. And this is a small thing, but in another way, it's a very big thing. Okay, let's go to the other end of the continuum, to the front of pack warning labels. I think that's an example of an agentic intervention, and I think it's an example of an intervention that has the possibility of actually increasing nutrition disparities in our country, or introducing disparities in a place where we don't have them now. The simplified format of the front of pack label is something that's seen as good because it will circumvent barriers to literacy or to health literacy, making it easier for people to identify poor choices. But if the experience of reformulation that is stimulated by this front of pack label is anything like the reformulation that we witnessed with trans fat, we can expect to see reformulated products, that is, those with lower sodium, saturated fat, or sugar content, we can expect them to be at higher prices. The other thing that we can expect to see is increases in prices of foods affected by this labeling, or of products, I would say, produced by companies affected by this labeling. It will cost industry money to relabel their products, to put this mandatory warning label on the front of pack, in the same way that it's going to cost them money to reformulate so that they can avoid having to put that mandatory label on the front of pack. Those costs will not be borne by the shareholders of those companies. We can expect them to be passed on to Canadian consumers. And so insofar as there is a segment of our population who is sensitive to price, we can expect that sensitivity to be exacerbated by this particular intervention. What about the restrictions on marketing to children? Well, There are some studies that have indicated greater screen time for children from low-income households. This is not a robust body of literature by a long shot, but insofar as children of lower income households are more likely to be exposed to marketing because they spend more time in front of screens, the lessening of marketing may impact them more. There's also some evidence in some parts of the country, not all, that low-income neighborhoods are more exposed to fast food outlets than others. So again, insofar as marketing to children includes marketing around fast food products, we can expect a shift in terms of the exposure of children in these neighborhoods to things that they're seeing in their neighborhoods. But there is a question. There is a question. You getting? Okay. And that is, to what extent are the purchasing behaviors and the dietary intakes of children in low-income households impacted by food marketing at all? There's been an enormous amount of work done over the years to study food provisioning in the context of low income. And I think Canada needs to be very proud of the volume of research and the quality of research that we have on food provisioning in the context of low income in Canada. There are two themes that come through from that literature loud and clear. One is the extraordinary labor that it takes to provide food to families with a constrained budget. Mothers from low-income families that have been interviewed repeatedly talk about the work of sourcing the cheapest possible foods they can source, working with advertisements for sales, timing themselves to go to places when foods are marked down, traveling huge distances to try to get cheaper foods. There's a ton of work that goes into sourcing low-cost foods. There's also very, very careful attention to food preferences in low-income families. And that is because nobody can afford to waste anything. What gets bought has to be eaten. So whereas a higher-income household could buy peas and serve their children peas because they wanted to expose them to peas, and they wouldn't care if every night they threw away those peas, it was still, they're, modeling peas. Low-income families can't contemplate doing anything remotely like that because they can't afford to throw those peas away. So there's a very careful attention to preferences, particularly the preferences of children. To the extent that those preferences are reflecting food marketing, maybe some of that pressure will be lightened. There also is a whole logic that people talk about in terms of the use of convenience or prepared foods, and that logic is all about trying to fill bellies and make good use of money, creating a meal, even if it's a craft dinner or a packaged meal or a dried noodle product that you just add water to. It might seem like a very bad choice, but for somebody who's struggling to put food on the table, it's a good choice because it's a complete thing that they don't need a bunch of ingredients for. They just had to buy one thing to do. What's also abundantly clear through the logic of people's food purchasing decisions in the context of low income is that price trumps health. Every time, price trumps health. And so agentic interventions, behavioral interventions that are supposed to be helping people to identify healthy choices are unlikely to impact these people because they can't afford to be impacted that way. Their pressures are elsewhere. The healthy eating strategy falls into another kind of a category that is consumerist intervention. It's what's called a consumerist model of intervention, and that the focus of that strategy is on consumers. Over and over again in nutrition, we've heard this refrain, making healthy choices the easy choices. Yeah, okay. And we've heard that at this conference multiple times. I'm sure we're going to hear it again. Okay. But if you're thinking nutrition equity, the part of all of that little refrain that you need to pay attention to is the word choice. The healthy eating being, healthy choices being easy choices is all about consumer choices. So if we take a look at this strategy more closely, okay? The sections of it can be grouped, I think, quite clearly. The work that's been done already on the nutrition facts table and the ingredient list and the front of pack label that we're going to see are about supporting informed choices. The phrasing of the work on marketing to children in the healthy eating strategy is phrased as protecting vulnerable populations. What are we protecting them from? Marketing. So again, a focus on the child as consumer, the parents as consumer, intervention as impacting the consumer behavior. Interventions to stimulate or mandate product reformulation could also be seen as improving consumer choices. We haven't yet seen the famed Canada's Food Guide, the long-anticipated Canada's Food Guide, but Health Canada did some time ago post guiding principles. Again, I would submit to you that those guiding principles are about making better informed consumers, helping people to navigate a very complex and problematic food supply, and out of that to source, a healthy diet. That all works as long as you've got purchasing power. But we actually have a fairly large segment of our population that reports some difficulty accessing food because of affordability issues. What you're seeing here are the results of the Household Food Security Module as it was administered in 2011 and 12 in the Canadian Community Health Survey. In that cycle of and that's the most recent national data that we have. In that cycle, 12.4% of Canadian households reported some difficulty affording the food that they needed. This absolutely is a story of purchasing power when you look at the questions that are asked to generate that preceding graph. There are 18 questions that range in severity from people worrying about not having enough food, running out of food because they don't have money, through to people compromising the quality of the food that they eat, and then a series of questions asking about compromises in food quantity. So cutting meals, cutting portion sizes, skipping meals, going hungry without eating, and finally going whole days without eating, all because of a lack of money for food. Food insecurity is a measure of material deprivation. There's no question about that. This isn't a food problem. This is a problem of people not having enough money to afford the food that they need, or at least that's what's being measured. What you're seeing on this graph is the relationship between food insecurity mapped out in those 3 levels of severity in relationship to income. And you can see a profound gradient whereby the lower the income, the greater the probability that someone will report struggle to put food on the table. The relationship between food insecurity and income isn't a perfect relationship. We can find people with low incomes who report food security, and we can find people with higher incomes who report food insecurity. So it's not a perfect relationship. And people like me spend a lot of time trying to figure out why that relationship is not perfect. That's what you do if you work in the area of food insecurity. You study that graph, and you study it and you study it. And what I've come to conclude, and we'll see if you agree with me or not, the reason food insecurity is not perfectly related to income is because it's actually a better measure of material deprivation than income is. By the time somebody is struggling to put food on the table for themselves and their children, what we're seeing is the product of their income and their assets and their expenses. What comes together in that moment is the stability and the security of the income as well as its amount. And all of that juxtaposed against the cost of living that the person needs to realize in that particular location. Layered on top of that are issues of asset, credit, and debt, whereby someone with a low income can function because they own their own home, they have relatively low out-of-pocket expenditures. Someone with a higher income is struggling because they're in debt up to their eyeballs, their house is mortgaged, and they're about to move down that ladder. So what we're getting is, I think, a very meaningful relationship between food insecurity and income, but it is about the fact that what food insecurity is capturing in our population is a very, very sensitive measure of material deprivation. It has nothing to do with food skills. Here you see the relationship between food insecurity status and self-rated cooking ability drawn from a rapid response module that Health Canada had inserted in the Canadian Community Health Survey in 2012-13. There's no indication that people who are food insecure have any less ability to prepare food. They look exactly like the rest of us. When we look at their shopping behaviors, they also look very similar to the rest of us. They are very likely to make grocery lists, to work through nutrition labels. They're as likely as anybody else to use Canada's Food Guide in the context of shopping. The one place where they differ hugely, though, is in the likelihood that they will have a budget in order to shop. And of course, they will shop with a budget. After we take into account things like age and sex and education here, there is a 4 times higher odds of people who are food insecure talking about using a budget. So again, it reinforces the understanding of food provisioning that we've garnered through the qualitative research on this topic, that price is a major, major factor, and that people are working hard to maximize their food dollars when they shop. What you're seeing on this slide is household expenditures. This is us taking data from the 2010 Survey of Household Spending. So a national survey looking at a very detailed measure of the way that Canadian households apportion their dollars. These are the household spending patterns on average of food-secure households from that survey. And you can see at the very top a red bar that is spending on food, and then through clothing and housing and other sorts of necessities, discretionary expenditures, and other sorts of investments in assets and future durables. So now I know you're looking at this thinking, well, this isn't me, I spend way more than that. Well, these are averages. These are averages. This is the average of the food-secure population, their spending patterns. And you can guess, I showed that to you just so that you can get the picture for this next one. People in food insecure households represent a completely different consumer group. They spend less on everything. The bottom bars are the deficits in spending when we take the household expenditure patterns of marginally, moderately, and severely food insecure households and we contrast them to the spending patterns in that first bar of the food secure. They spend less on absolutely everything. They have less, they spend less. Take a look at the red bar for food here, though. It drops, but it doesn't drop nearly as much as some of the other spending categories. I'm showing you this for a couple of reasons. One, to again make the point that to be in a food insecure household is to be constrained financially, and that manifests in a number of ways in terms of spending patterns. Food is only part of the decision making in these households, and it's only part of the expenditure pattern, right? The deprivation is pervasive. We could I could be standing up in front of a conference of dentists talking about these people's oral hygiene and their ability to afford dental care and dental hygiene aids as talking about nutrition. But it's important to get your head around the red bars here, because conversations about intervening at the level of food or food price are working under a very low ceiling, given the pervasive level of deprivation that's manifested both in the experiences of food insecurity and in the spending patterns. The health effects of food insecurity are also very, very broad spectrum. What I have in this slide is a summary simply of literature from Canada on health in relationship to food insecurity. Like all of the literature on food insecurity, this is an area that continues to pile up. And we can see the effects of food insecurity on health across the life cycle. Amongst children, children in food insecure households have poor developmental outcomes. They are more likely to develop a variety of chronic diseases, including things like asthma and depression that they will be having to manage for the rest of their lives. There's also indications that children in food insecure households are less able to manage chronic conditions like type 1 diabetes. When we move to the adult population, the evidence is even more replete. We can see higher rates of both communicable and non-communicable diseases amongst adults in food insecure situations. And we can also see very, very strong indications that someone who is food insecure is less able to manage their condition, irrespective of whether it is a physical condition or a mental health condition. Diet-related chronic diseases like diabetes and heart disease and hypertension, they're in here. For sure they're in this list, but they're nowhere near the biggest. You know, we can find effects or find differentials in health in relationship to food insecurity across the full spectrum of health conditions that you can imagine. Okay, sorry. So it could be argued with slides like this one and the one before that food insecurity really doesn't, sorry, I have a way longer speaking period than anybody else on the agenda. I don't know if anyone else has noticed that, but let's just say I did, and I'm unfortunately at an age where 45 minutes is a bit longer than this little old voice will work for. So forgive me if I stumble. So with this list of health conditions and with the prior story about expenditure patterns, we could say, well, there's no place. This isn't a food problem. It isn't even really exclusively about diet or diet-related conditions, so why are we talking about it? Well, yes, that's all true, but food insecurity is the single biggest and strongest indicator we have of nutrition inequities in this country. And the effect of food insecurity on nutrition is palpable. I've got something here. Thank you very much. I'll try that, though, if you like. The effect of food insecurity on nutritional health and well-being is evident practically at the point of birth. This is us looking at the probability of the prevalence of exclusive breastfeeding amongst infants born to women of differing food security status, again using data from the Canadian Community Health Survey. Women in food insecure households are as likely as everybody else to start breastfeeding their infants. There's no difference there. It kind of goes back to the comment that Kim Rain made this morning, that they know what's good for them, and they know what's good for their children, and they want what's good for their children. So they're as likely to start breastfeeding as everybody else. But by the time we hit 1 month of age, we start to see a separation in the probability of them continuing to breastfeed. And as we go down the ladder to the magical point of 6 months of age, where the recommendation is, by that point, food insecure, or infants in food insecure households look very different than infants in food secure situations in terms of breastfeeding. Not only is this a problem because it's the beginning of life, and it's the beginning of disadvantage, a long life of disadvantage, I would argue, for these kids. Not only will they not realize the benefits of exclusive breastfeeding that are extremely well established, but these families are not able to afford formula. I think that's why low-income supermarkets supermarkets in low-income neighborhoods sell formula like this. This is a picture that a student took in a discount supermarket in a low-income neighborhood in Toronto. I've done a bit of emailing, and it's my understanding that this is not uncommon. There's only one reason why a supermarket would be keeping formula under lock and key, and that's because it's stolen. There's a black market for formula that's part of the theft story, but also if you read the very heartbreaking qualitative literature of people like Leslie Frank, who's interviewed women who gave birth, they talk about stealing formula. So it's just part of the cascade of what it means to have recommendations that are based on the idea of making healthy choices, the easy choices, without recognizing this rather big barrier to choice. The issue of food insecurity as a measure of nutritional inadequacy or inequity is persistent across the life cycle. This is work from Sharon Kirkpatrick from using the 2004 Canadian Community Health Survey, and what you can see are higher rates of inadequate nutrient intakes amongst individuals 9 years of age and older based on food security status. We are currently in the process of working with the 2015 Canadian Community Health Survey. I can tell you that we are going to produce results much more impressive than these ones, and with a much longer list when we finally release those data. The situation is not getting better. In the healthy eating strategy, there is a nod to food insecurity, and it comes in the form of a statement about increasing access and availability to nutritious food through strengthening a program called Nutrition North Canada. That is a subsidy program for retailers in isolated northern communities that is intended to subsidize their costs so that they transfer to consumers a lower cost for perishable foods. It's good that the healthy eating strategy is acknowledging that there is an issue of access to food in the north. This is food insecurity and Nunavut from 2015-16. Nunavut, ever since we started measuring food insecurity in Canada, Nunavut has had by far the highest rate of food insecurity anywhere. 2015-16, they topped the charts again, and in 2015-16, we are charting the highest numbers we've ever seen there. 51% of households in Nunavut in those years report some level of food insecurity. Everywhere in Canada, households with children are disproportionately exposed to food insecurity, but nowhere is that more concerning than in Nunavut, where 72% of children under the age of 18 in 2015-16 are living in food insecure households. There is no indication that Nutrition North Canada is an effective response to issues of access or affordability in Canada's north. There's been extensive work done by an anthropologist called Tracy Galloway, who's at the University of Toronto now, and she writes well about the failure of both the structure and the regulatory framework for Nutrition North to ever enable that intervention to achieve its goals. Recently, we have partnered with Tracy Galloway to do an examination of food insecurity in communities in Nunavut that are receiving this intervention. We're drawing on data from the Canadian Community Health Survey again, and I have a very talented doctoral student called André Fafard Saint-Germain who's been doing this analysis. What we can see is through the implementation of Nutrition North, food insecurity in these communities that are receiving Nutrition North has actually risen. So while it's laudatory that this problem has been identified in the context of the healthy eating strategy, it's concerning that the response is to strengthen Nutrition North. I was asked to talk about progress and opportunities, and I thought in these last couple of slides I'd say something positive. I only have a couple of minutes left, though. It won't take long. It's okay. I'm safe. Progress. I think there's been progress on food insecurity. Most importantly, we have a commitment to monitoring, and that was a gigantic thing to get. And now it's almost taken for granted, but it was very big. And the only way we even know we have this bigger problem is because it's been rendered visible through monitoring. I believe it's fair to say that we also have widespread awareness and consensus among both public health and civil society that there is a need for policy intervention to address food insecurity. I think we're at a place now on this topic that we have not been before in terms of a whole bunch of very disparate players coming together around the argument for policy intervention. The other thing that I think we've garnered largely through the monitoring is a growing body of evidence about what moves the needle on food insecurity. We know an awful lot about how to change this problem. And I want to take issue with the times through this conference so far where I've heard people talk about it not just being about money. If you want to move the needle on food insecurity in Canada, the only thing that we have seen so far that moves that needle is income. So those of you who think this isn't just about money, I want to take each one of you outside afterwards, behind the building, and we'll have it out, because I have yet to see a speck of evidence, and I've looked for it, and taxpayers have spent a lot of money helping me in that search. I have yet to see a single speck of evidence of anything that lowers food insecurity other than income-based interventions. We now have 4 papers using national data from the Canadian Community Health Survey looking at interjurisdictional changes, looking at temporal changes, and looking at intergenerational impacts. And what we are seeing is that where income-based policy improves the incomes of people at the very bottom end of the income spectrum, guess what? They buy more food. That's what happens. When you are food insecure and somebody gives you more money, you don't want to be food insecure. You move that money into food and other basic necessities as soon as you can. So the conversion rate is very fine. We're about to have even better data coming out of the province of Ontario because we have effectively a randomized control trial running right now in the form of the Basic Income Pilot. A primary outcome of Ontario's Basic Income Pilot is food insecurity. Why? Because it is one of the most sensitive measures anybody's got that's going to show an impact quickly of the change in income that the control group, or the treatment group in that study is going to get. What is the opportunity? Well, I think we're at a unique place in terms of policy in Canada. People have repeatedly mentioned the mandate letters that stimulated or at least are symbolically stimulating the healthy eating strategy. And the Minister of Health isn't the only minister who received a mandate letter. I think the much more important mandate letter is the one that went to the Minister of Employment and Social Development in Canada, and that's one that mandated a federal poverty reduction strategy. We're also seeing the emergence of a national housing policy, and I have grayed out here a national food policy because I'm less optimistic about its power to impact, importantly, things like food insecurity. But I think we are at a critical juncture in policy in Canada, where we have an opportunity, particularly through the federal poverty reduction strategy, to embed food insecurity reduction as a policy outcome, and that's what needs to happen. It is not enough to have these vague promises of reducing the proportion of children living in poverty. What we need to see is a drop in the number of children living in households that are struggling to put food on the table. And that's related to lowering the number of children in poverty, but it's actually not the same. And it requires a very different and much more deliberate kind of policy intervention than we've seen so far. But there is no reason why things like the Canada Child Benefit cannot be designed to enable families to feed their children and themselves. It's outrageous that that hasn't happened yet. So I think as an opportunity moving forward, people have talked about advocacy and the discomfort of advocacy in this conference. But as you can see, I didn't pay close attention to that part of the earlier. So I just want to say that I think that it's extremely important that food insecurity be on the agenda. And not to say that it's something that food policy can fix, but for us to have an healthy eating strategy that can benefit all Canadians, we absolutely need to deal with the 12% who actually don't have steady and secure access to the market. That's it. Thank you very much for including this.
I'm actually here, to be honest with you, I'm representing a lot of public health nutritionists across the province. The only reason I'm here is that I live in Calgary, is the primary reason. So we all focus on health equity, and then obviously nutrition being the other focus. What I was hoping to do is try to represent what we look at when we're looking at policy sort of on the ground level. So what we're doing with actual populations and clients that we deal with on a regular basis. So what's amazing is most of our work will actually be based on what Valeria Tarasuk has researched. So I'm sort of an extension of what she's already said. And I just have actually 4 quick points, so hopefully I'll be less than 5 minutes. The first one that I know as public health dietitians, what we look at is we always try to make sure that we are involving the actual vulnerable populations who are experiencing the inequities in the development of policies or programs that are intended to support them specifically. So a lot of people talk today about the amount of engagement that has happened across Canada around the things like front of package labeling, et cetera, and that's all been really, really important work. But if it hadn't been for some of the research, for example, that Val Tarasuk had done, we probably as dietitians would have never figured out that income was the issue. It wasn't so much food. So when we look at food policy as dietitians, what we want to make sure is that it is never separated from income policy. They need to happen together at the same time. They can't actually happen individually, or else we're going to miss the big boat on the whole thing. An example of that would be even the front of package labeling. Of course, as dietitians, we fully support it because we know we can use it as a really great education tool to help the entire population understand their diets better. But one of the things clients taught me probably in the first 2 weeks of working as a dietitian is that when you're trying to make food choices out of desperation and deprivation, they will very likely never be based on an informed decision from a front of package labeling. It doesn't mean we shouldn't do them, but it just means we don't want to separate that whole policy from the reality of those people who we're really trying to help. The second point I'd make is that, again, as dietitians, we really try to focus on policy that's actually going to support everyone who is experiencing the inequity. And I know that everyone here who talked today, a good example being the marketing to children, we know why they're doing that and we fully support it because we know that children are vulnerable, period. Regardless of their income, regardless of their background, children are highly vulnerable. But when you work with clients individually or with bigger populations, the other thing you see is that there are thousands upon thousands of adults who are, in our opinion, equally vulnerable to what I would call nutrition misinformation or nutrition pressure that they actually don't necessarily have to follow. The interesting thing about the marketing of food is that even if we removed that from children, it's going to be adults that are primarily buying a lot of that food for kids. So all you have to do is shift the marketing towards parents to say you'll be a great parent if you provide this food to your child. So again, it'd be great if those policies could go a lot deeper. There are a lot of adults who experience barriers based on a lot of other issues, even if they don't have children. So I always think of those unattached single adults who live in poverty as well. They are pressured to follow a lot of the diet messages that actually are either not founded in evidence or that they don't necessarily have to follow to maintain a healthy life. So again, policy should really look hopefully at everybody and not specific groups only. The third point I had was around, which no one has talked about, but I wanted to bring it up quickly, is just not to confuse policy, important policy that's focusing on sustainable food systems and sustainable diets, as policy that will then reduce household food insecurity. So we know that that will not happen. It's an income-based issue. No matter where your food comes from, you're going to have to pay for it. So those policies are important, but I know, for example, within a food guide, I would want to be very careful in how we framed the concept of sustainable eating and sustainable diets. Sometimes those types of eating patterns are very expensive. So again, you're going to be putting pressure onto people who are facing all kinds of deprivation already to now follow something that's even further outside of their reach. And then my last point would be around the fact that we know that income is the common denominator for all of the groups who are struggling to eat healthy, but I don't want to neglect some of the other social barriers, none of us do as dietitians, that they also face. A really good example would be weight stigma. So a lot of our policies, we constantly repeat the need to reduce obesity, and reduce obesity. What that can do in the public eye is sort of give the impression that someone who is overweight may not have the knowledge, the skills, or the actual motivation and inner strength to make changes to their diet, so therefore we have to do it for them. That's not what we're saying, I realize, but I just want to make sure that we have to be careful in how we frame policy, because it can come across that way. There are a lot of other groups as well who are going to be facing both an income double-barreled barriers. We know all of those people, Indigenous heritage, people of different cultures, LGBTQ, and people who are struggling with mental health issues or even a physical or cognitive disability or impairment. So I just don't want to forget them when it comes to the policy piece either. And that's it for me. Dina? Yeah.
Thanks again, Donald. Next, we will hear from Bobbi Turko. Bobbi has really inspired me. She and her daughter Sutton founded I Can for Kids. And this is a program that provides nutritious meals to low-income children in the summer when they no longer have access to school meals. So Bobbi's going to tell her about her journey in this process and what she's doing to support good nutrition in children.
Thank you. Good afternoon. Before I get started, I have to come clean. Last night, after I left the session here, I was super inspired, and I went home and I ate a piece of pie. And I liked it. The I Can for Kids story started back in 2015 when my 11-year-old daughter and I were watching an episode of Good Morning America, where they featured a story about children in the US going hungry over the summer months. It was an ongoing concern for thousands of kids over many years, but only in that moment did it seem so incredibly obvious to us. Curious about kids in our own community, we did a little digging, and we soon discovered the same thing was true right here in Calgary. The majority of kids who counted on school-based nutrition programs during the school year did not have the same access to a free meal during the summer. Their options were limited, and we learned the resulting hunger could seriously impact their physical, emotional, and social health and delay their academic performance by up to 2 months at the start of the school year. So, armed with our best intentions, our family decided we would take on this summer hunger challenge. Although not new to the charitable sector, we were new to providing hunger relief programming. We had the heart and the passion, but we were a little shy on the expertise needed to fully appreciate food insecurity, its impact on children, and what type of program would be effective for the kids we wanted to support during a critical time of the year. We had a lot to learn. So we surrounded ourselves with a strong knowledge base with professionals with a strong knowledge base in research, health and nutrition, child learning and development, social services, as well as look to resources like the Canada Food Guide to assist us in the development of our program, a practice that still holds true today. We also talked to those affected by food insecurity, understanding household dynamics, how hungry kids live, learn, and play was important to us. We needed to understand what they wanted, what they needed, and how the fear of stigma and social and physical barriers were making it difficult to feel supported. We wanted to create a program that was meaningful to them, not as clients, but as human beings. With all of this in mind, we created a unique feeding program that reaches the hungriest kids where they live and play all summer long. We support children trapped in the cycle of poverty, young victims of domestic violence, and homeless youth as young as 12 years old. In only 4 very quick years, our program has seen growth of 450%. With nutritional value top of mind, there's much to take into consideration when wanting to reach a large population with diverse dietary needs and preferences. Providing fresh is best, of course, but the capacity needed to do so is a considerable challenge. Other factors such as ease of preparation, enjoyability, understanding items provided, and limiting food waste also weigh in while creating an accessible program and an efficient delivery system. Compromise is required. We can't do it all, but we endeavor to make the right choices within the confines of offering a program that reaches thousands of kids by a volunteer team of only a few. Throughout this journey, one thing is very clear. Food insecurity is a dynamic, intensely complex issue associated with many factors in addition to poverty. The solutions are equally as complex. From an agency perspective, we need to do more to challenge the system that creates food insecurity in the first place. We need to be active participants in moving the needle. While we focus on short-term programs to address the immediate need, we need to work together to address the social inequities that drive hunger. Supporting and advocating for thoughtful policies that strike a balance between genetic and structural interventions are steps in the right direction. Although grateful for the opportunity to provide support, the support we do each summer, there would be nothing more satisfying to us than seeing policies that eliminate the need for programs such as ours in a manner that upholds the dignity of those challenged to meet their basic needs. In the meantime, to best serve the needs of individuals and families struggling with understanding the intricacies of healthy living, the evolution of resources like the Canada Food Guide will be most effective when they take into account the realities of today's society, such as our ethnic and cultural diversity and challenges with food access. Before my family started down this path, ignorance was bliss. It took a media story to get our attention. It took much more than that for us to truly appreciate the impact of food insecurity and to understand its complexities and solutions. Perhaps the most meaningful question we asked ourselves in the beginning wasn't how do we make it better, rather what happens if we don't? And is that a price we wanted our children to pay? Thank you.
Thanks, Bobbi. And now you can see why she's so inspiring. Next, we're going to hear from another very inspirational person, that is Mary Salvani. Mary is a tireless community advocate at Disability Action Hall, and she volunteers in a large number of community programs that assist food insecure Calgarians to access healthy foods. So we'll invite Mary up now.
Thank you for inviting me. Good afternoon, everyone. My name is Mary Salvani. I'm a self-advocate, a person with a disability and low income, and an ally for people who have disabilities and low incomes, who does advocacy work on behalf of the Disability Action Hall. I'm glad that Valerie mentioned the connection between poverty and food insecurity. I'm also glad that Valerie mentioned the need for basic income. Basic income, for those who don't know, is an income that's guaranteed regardless of age, race, sexual orientation, disability, to help people who cannot otherwise access things like healthy food. It is hard to access food when poverty is present. It is even harder for a person with a disability to access food that is affordable. For example, I live in a community that is 100 years old, the community of Inglewood. It has no major grocery store. Due to having a mobility disability, I use a walker to walk. The only store in Inglewood that sells food is a place called Bite. It is not accessible. The aisles are too narrow for me to walk down with my walker. Bus 411 stops by my place. It does not go to any grocery store, farmer's market, or even the Good Food Box. The building I live in is a subsidized building for people with low incomes, some of whom, like myself, have disabilities. If a person with a low income wants to get a regular transit bus to get groceries, they must walk 1.5 kilometers to catch number 1 bus to go get groceries along 17th Ave Southeast in Forest Lawn. There is no bus to go to the nearest farmer's market in Ogden. In other words, for someone like me to get groceries, I have to go down to City Hall, get my bus pass there, then go down to 17th Ave and purchase food. As some of you may be aware now, 17th Avenue Southeast is under construction. Most of the bus stops are inaccessible and unsafe for me to use. For example, last year there was an elderly man who was trying to go to a food center that's in that street, and he actually got hit by a car because he could not safely access the crossing. To keep my travel short, I go to the nearest grocery store I can get to, Calgary Co-op. It is not very affordable for me to shop there, but that is the price I pay just to make sure I can get food on my table to eat at home. I go there because it's the most accessible place out of all the grocery stores on 17th Ave for me to buy stuff. Like Valerie stated, 1 in 8 homes are food insecure. To address this issue, I have 2 places I can go to in my building to get some food. I can get fresh and processed food, yet soon to expire, from my supported living coordinator whenever she's in her office. The food she provides comes from the Calgary Food Bank. I'm lucky that I can access this food when she's in her office. Not everyone in my building can access the food. Only those who have a supported living coordinator can. The rest get to stare at it through the office window. The second place I can go to is in the kitchen in the main lobby downstairs. Everyone who lives in the building can get food there. When people have extra food to share, or when they're feeling generous enough to donate food, people put food in the lobby fridge. The fridge is provided by my landlord. The food in it is free for taking without any question. Neither my landlord nor the agency that provides me with the support worker are required to provide this type of service. They are doing it because they realize that we live in a food desert and that the food is unaffordable for many of us tenants in the building. I feel blessed I can go get food from these places. I also know when I am hungry on certain days and too tired to cook something healthy, or too broke to buy something healthy, I can get a free meal. Monday dinner, Wednesday lunch, and Friday breakfast at the Alex Community Food Center in Forest Lawn. I have taken all their classes there, including the cooking classes, the gardening classes, and the social justice class. So I know how to take care of myself. Five years ago, when I first moved into Inglewood, I got my own plot where I can grow my vegetables in the Inglewood Community Garden. When I first came to the garden, I didn't even know what a plot was. So I asked the people, what's here? And they asked me, do you want a plot? I thought, well, are you meaning funeral plot? Because the answer is no. As part of the contract, I volunteer with them as well. My reward for volunteering with them is a minimum of 5 hours per season, is that I get 1 pound of free veggies for every hour I work there. Not everyone has the worker, the landlord, that cares to help people who are food insecure. Some people don't have the ability or the money required to travel to the Alex Community Food Center for a free meal. Some people don't have a community garden that gives a free plot to the poor gardeners, nor one that provides free food as payment for volunteer work that's done. I feel lucky to have those things, but I am aware that not everyone has that available to them. Dr. Jose Rizal, my idol and national hero of the Philippines, once stated, "Education is the key out of oppression." Valeria stated that too. I also agree with that statement. If a person is educated about which food is healthy and which food isn't, the chances of them eating healthy and encouraging their loved ones to eat healthy food increases. If a person can read, they can choose the food they want to buy. The other night, I asked the members of the Disability Action Hall, if money was no object, what would you like to eat? I thought the group would say something like, I want steak, lobster, or something exotic and expensive. But I was wrong. Each member in the group said they wanted food that is grown locally and born in Canada. We talked about we wished we could get bacon from locally born pigs, real maple syrup from Quebec, and fresh fish from the oceans in the Maritimes. We wish we could support our local food and agricultural industry. In reality, we don't have enough money to do that. In 2015, I became a student in the Humanities 101 program at St. Mary's. For those who don't know, St. Mary's University's Humanities 101 program is designed for adults who've experienced barriers to learning and low income. The school covers the cost of tuition, books, school supplies, bus pass, childcare, and healthy lunch. I wish U of C did that too. I graduated from the Humanities 101 program with honors in 2016 and transferred over to the St. Mary's University Bachelor Liberal Studies program, where I'm currently a part-time student. The school has continued to support my education. They pay for 90% of my tuition through 2 bursaries. This past semester, I've taken the Health and Nutrition course as part of my degree program at St. Mary's University. In that class, we learned about stuff such as the importance of taking vitamins, eating healthy food, food security, and food dignity. I've completed all the classes, also, like I stated earlier, I completed all the classes at the Alex Community Food Center as well. Not everyone's had the opportunity to take cooking classes and nutritional classes tailored to meet the needs like I have. For example, some agencies that serve people with disabilities used to offer cooking classes here in Calgary, but they're not doing that anymore due to budget cuts. Valerie stated in her presentation, the effects of social inequalities depends on nature of intervention. I firmly believe that with the right supports in place, provided by people who are trained in caring, people with low incomes and disabilities can succeed. For example, last September, I became a brand new patient at the Alex Community Food Center. Prior to that, I never thought I would enjoy going to the doctor's office so much as I do now. The reason I like going there is because the staff treat me like a human being. Not a number, not a medical puzzle that needs to be solved. They treat me well. I feel like I can trust the staff with my thoughts and ideas without fear of being judged. Most of my medical needs are met on site. I see my family doctor there. I get massage therapy there. I get my lab work all done. And sometimes I get lunch there. And I see my friends there. Not everyone with a disability has that luxury. Caregivers sometimes make choices for them, including what and with whom they want to go and do things like eat a healthy meal. Out of necessity, I've learned to become resourceful. I've had to figure out ways to get support for myself on my own, which is what I have done. While hearing or reading the word no hurts when it's mentioned, I don't allow it to stop me from getting what I need. I may be disabled, I may be poor, but I let neither of these things define me. I define myself. In the keynote presentation, Valerie did state, individuals must attend to and act on information provided. Sometimes that means they gotta swallow their pride by sharing their story again and again to different levels of government, agencies, and people. For example, a person on disability who needs assured income for the severely handicapped, also known as AISH, The low-income bus pass. Food from the food bank must say the following over and over again every time they apply and reapply for those programs. I'm poor and disabled. No one wants to admit they're poor and disabled. No one wants to admit they need help. The myths and stigmas associated with poverty and disability cause people who are poor and disabled to be ashamed of their situation. It takes great courage to overcome that shame and to get assistance when needed. No one gives disabled people and poor people credit for being resourceful self-advocates. Thank you.
Thank you so much, Mary. It was really amazing to have a really first-hand perspective of what you experience in your life. And finally, we're going to hear from Chelsea Crowshoe. Chelsea is a member of the Piikani First Nation and works in Indigenous health within AHS. And there she focuses on building cultural competency for AHS employees. And this helps to play a role in ensuring that Indigenous populations and their families actually have positive health experiences and outcomes within AHS.
Good afternoon, everyone, and thanks for the introduction. Thanks for having me. First, I'd like to just acknowledge Treaty 7 territory and welcome you to Treaty 7 territory. Also want to acknowledge that June 21st is National Indigenous Peoples Day, along with first day of summer, which I think we will have an actual summer day here in Calgary. So excited for that. Please check out all the events that are happening in your area. First, I would just like to say I'm not an expert in nutrition. I'm not an expert in nutrition policy, but I just want to give you a bit of a glimpse into an Indigenous lens when it comes to what we've been talking about, food insecurity, and especially access. First of all, the Indigenous population is very diverse. Here in Alberta, we have like 44, 45 First Nation communities. We have 8 Métis settlements, and access is a huge thing. We're looking at urban and rural communities. We're looking at isolated fly-in communities. And when it comes to access for food and quality of food, I think we need to talk about is the price of that is huge. And when we do have a disproportionate unemployment rate within the Indigenous population, in a higher incidence of chronic disease, diabetes, etc., what does that look like for that family or for that, say, single parent family, which there are a lot of? Not only that, the makeup of families, you're going to have multi-families within one household. What does that look like? You have grandmas and grandpas and aunties and uncles and cousins and people who are moving back and forth. What does that look like for trying to feed all those people and trying to with a low income? So it's really looking at those social determinants of health that I think that we've been talking here, and how does that impact us? Looking at housing, access to housing, having those multifamilies in a house. There's so many things that are going to affect our well-being and health, not only from a food point of perspective. When looking at cultural diversity, there's Indigenous population ranges from different cultural backgrounds, different language groups, different spiritual, traditional practices. What does that mean for them when it comes to food? How do people identify with food? Culturally, how do people identify with food? Not only the Indigenous population, but other cultural groups. How do I identify? How do we define that food for us? Within our history has played an impact within the health of Indigenous populations. Access to food when reservation system came into place. There were food rations, and what did those food rations include? White flour, sugar, lard. What do you do with that? So adaptations had to be made in regards to the food and things that they had access to at that point in time, which has affected the health of Indigenous populations currently. I really think we need to look at, what are those economic opportunities within on reserve? There's limit, each First Nation community will be different, access to different opportunities when it comes to economic development, hence job opportunity. So a lot of times you have Indigenous families or people moving off reserve to access economic opportunities, education opportunities, to provide for their family, because there's going to be few opportunities for jobs within that community. I think really looking at social determinants of health and looking at holistic approaches that First Nation Indigenous populations look at, focusing on the spiritual, emotional, mental, and physical aspects, really is a part of that understanding of how does food play into that, how does nutrition play into that. when going into policy and guideline, I think we really need to look at adaptations, modifications, respecting those cultural differences that can impact that, and be able to allow for those modifications, adaptations for those groups, or for the way people view things, and to support that when translating that, say, into education materials. And what does that look like? Because way people learn will be done differently. Understanding of that will be done differently. So it's like, how can we support that family where they're at that moment in time? And I think that's when we talk about equity is huge, and a lot of people get equality and equity mixed up. It's like we need to sometimes support that extra aspect for that person at that moment in time. They might not always need it, but if they need at that point, what can we do to do that? And we really need to do that patient-centered type or client person-centered approach when looking at these policies as well. So there's a lot of great opportunities. There are a lot of things happening within in First Nation communities and urban and rural settings when it comes to programs and initiatives. We talked about community gardens, that's happening. And there's just different ways. There's different exercise programs that are happening within the community. And there are those positive aspects, and having that community perspective is huge, especially within accessing those programs and being, have other funding resources, not only provincially, but falling under Health Canada, First Nation Inuit Health Branch for First Nation communities. So there's different perspectives we've got to look at when looking at the Indigenous population and when looking at policy as well. So I talk fast, I apologize, but if you have any questions at the end, I am here. Thank you.
So I thought we could actually just start by talking a little bit about the Nutrition North Canada program, because we really only got to touch on it very briefly, but as Valerie mentioned, the rate of food insecurity in the north of Canada is astronomical. So maybe we could talk a bit about what is currently being done to address food insecurity in the north, and maybe some optimal policy strategies. I would think Valerie and Chelsea probably have some ideas around that in particular.
I can't say that I have any ideas for ways to improve Nutrition North. When we look at food insecurity in Nunavut in particular, the correlates or the predictors of household food insecurity there are very much like they are in the rest of the country. It relates to income and to income source. Something like 83 or 84% of households in Nunavut that are reliant on social assistance are food insecure. So it's basically legislated food insecurity, right? There are higher rates of food insecurity amongst households with children, and so there we are in Nunavut with a greater proportion of households with children and this appalling level of food insecurity that children are being exposed to. I mean, I think, honestly, for me, the continued tinkering with food price as if this is an issue of food purchasing alone, and that it's about changing the price of food or trying to moderate the price of food as it relates to the transportation, focusing on that without putting food in the context of the total household income and the household budget, I think, is missing the boat. And that's why year after year the numbers are just coming in higher. The other thing I just want to say briefly about Nunavut is on the slide where I showed the rates of food insecurity, I also included a little note about the population. There are only something like 38,000 people there. Like, this is not a lot of people. I'm pretty sure that the street that I work on in Toronto has more than that. So this is an appalling problem because of the level of food insecurity. It's also, I think, an appalling problem because of the attachment to Nutrition North as the way forward, or before that, the food mail program, without any transparency in terms of any accountability for the impact of that policy on food insecurity. But given how small the population is and how severe the problem is, I think this is something that merits a different response and merits it immediately.
Okay, I also think, I didn't mention this, but looking at traditional foods, what does that mean? And going back to, what do people have access to? So hunting and fishing, and I know, there's environmental impacts as well in regards to that in some of the northern communities. But how does that make a play in food security for Indigenous populations on First Nations communities in the north? And so it's just something to consider when thinking about nutrition as well and policy.
So next, I thought we could talk about what a government program could look like to eliminate the need for your program, Bobbi. Have you thought about how government could more effectively deliver the type of thing that you do?
I have a bit of an opinion about that, actually. I think that as much as government may be well-intentioned, that leveraging the boots already on the ground and the expertise that already exists would be far more effective than a government trying to take over a program and deliver that themselves.
Anybody else have any other thoughts? I would imagine, Valerie, you have some thoughts on what government could do to eliminate the need for a program like Bobbi's.
Well, I want to ratchet back a little bit further forward, though, and say that programs like Bobbi's, I think, speak strongly about Canadian values. I mean, your story about the genesis of your program, I thought was absolutely beautiful. And what's the starting point of that story? It's you learning about people suffering, people not having enough to eat, and thinking, what can I do? How can I help? And I think over and over in Canada, we can see that story playing out in a whole bunch of ways, where people hear stories of appalling levels of food deprivation and think, what can we do? And it speaks to a Canadian value that I just think we have to insist be embodied in public policy, because it's everywhere except in public policy right now. And that's where it needs to be. So I guess that's what I'd say in terms of what can government learn from people like Bobbi. Well, to listen to how come they're doing what they're doing and think, what's our responsibility? I mean, these numbers like the 83% of people on social assistance and none of it that are food insecure, like, it's known. You know, these are deliberate policy actions that are in place and have been in place for a long time. And there's no accountability for how they relate to these problems. And yet, you know, these are governments of people like us, right? Who are inspired to take action, whether it's you taking a program on or me doing research in this area, because we're concerned about these issues. So I think the values that are embedded in your program are the values that I'd like to see embedded in the federal poverty reduction strategy.
And if I can also add, although I am here today, really the driving force behind I Can for Kids is my daughter. We started when she was 11. She's 14 now. This is our 4th summer of providing this program. She is on almost every delivery we make. This is how we spend our summer as a family. What is inspiring about that is this was not something on her radar, that this was an opportunity for a kid in the community to understand the challenges that face other children that she may not be you know, in daily interaction with, and being inspired to want to change that. And I think as long as we continue to engage our children in understanding the challenges that are happening, that perhaps they're even more part of the solution than anything else.
And Donald, how about from a municipal perspective or an AHS perspective? Have you thought of, you know, some optimal policies to eliminate food insecurity?
So I just want to make sure it's working. Actually, I think that there are things that have already started to happen, which are great. So municipally, they have, for example, even lowering or giving basically a free transit pass to people who are at a basic income. What I would offer as another way to maybe even enhance it further is to make sure it's graded. So what'll often happen with a lot of policies is as soon as you reach a certain income level, then you're cut off. It doesn't quite work that way. So I myself, I'm not sure if they have already done that. They may have, but I would grade that so that you're only, they have, yeah, I thought so. So I think within Calgary, there's a lot of great things that are happening. I think also within other industries, there are good things that are happening. So I don't just turn to government to solve everything. They're a huge power player in that. But even if you look at private industry, there are a lot of banking institutions that will provide free checking accounts to people, because we now all have to receive our checks electronically into our banks. So for some people, that's more than 1 hour of wages, right, to pay for a bank account like that. There are many banks that are actually trying to do that, again, based on income. So hopefully it's graded in terms of how much you pay for your account based on the income that you have. So there are quite a few different industries that could have a play in what's going on. And I think there are a lot of people who are really trying their best to do what they can. So those are examples of things I think that are going really well.
I'd just like to clarify, because I get to talk with City Council a lot. about the low-income bus pass sliding scale. I'm really grateful that the City of Calgary has provided that scale to us, but it is also funded by the provincial government, and that is up for debate this year if they would continue to fund it. So I'm encouraging people to vote and to do what they can to encourage the government to continue funding that program so more people can get to places they need to go.
Great, thanks everyone. And we have a question from, I believe it was online, and just commenting about fat taxes and sugar taxes and potentially how they might impact disadvantaged communities. But also, what is the potential for subsidizing food and whether that might be helpful, subsidizing healthy food in particular? Any thoughts, anybody?
I can start quickly, I guess. You know, it's interesting when you work with populations who are food insecure, they often do purchase certain what we call convenience foods for a lot of really good reasons. One is they're fast. Many of them are working 2 jobs or more. So if you're trying to feed a family or a household, they're fast. They're also predictable. So you know who's going to like them and who's not going to like them. So you can go that route. And then they're often pre-portioned. So it's also just makes it easier all around that way. I would have concerns, ironically, if we were to tax that, because a lot of people who live in poverty have actually, especially people who are new to Canada, have often told me they thought those foods were created for them to make their lives easier because they are working these 2 jobs. I wouldn't want to punish them for that very reason. So I am more of the style to actually promote subsidization of healthy food. So if we can get, in particular, produce. So if you look at fresh fruits and vegetables, there's very low cost to maintain them in terms of equipment, very low allergy risk, etc. I would rather just give out free fruits and vegetables to everyone that I could as a subsidy versus taxing them for something that we think is bad for them, but that we don't understand how they're using it. And they're using it in very interesting ways that I never would have thought of because I've never lived in poverty. So that's my take on that. But
I think it's really tough to make any meaningful dent in food insecurity through pricing policies related to food. And I need to, I guess, preface that by saying there's a paucity of data in Canada right now for us to look at the effect of food price in relationship to food insecurity. But given what we know about total household spending in relationship to food insecurity, I'd be very, very surprised if shaving 10 cents off the price of a head of lettuce or adding 10 cents to a can of Coke is going to move this needle one way or the other. So I think I worry that we get distracted into looking at pricing policies in relationship to food insecurity as if there's something we can do there. What I would say, though, is that we need to be cognizant of things like the recent reveal of the price fixing that went on for many, many years around bread. There are some fundamental injustices that it is important to be monitoring and to be cracking down on, because if we were to be capable of modeling the impact of that bread price fixing over 14 years, we probably would be able to see something because it's just so much money on such a basic commodity. But in terms of going forward from here, I would really push that we keep our eyes on income and income-based policy, and if we want to move beyond income into something else, I think it's a portable rent supplement. I don't think that the way forward is to start tinkering with food prices.